Okay, let's jump right into the deep dive. Today, we're tackling a topic that, well, it impacts a huge number of people, but it's still surprisingly tough to talk about openly. Premature ejaculation. So our mission here is to really unpack this. We're using source material from a medical expert, a urologist, and pelvic surgeon to break down everything you need to know about PE. You know, what it is, how it actually works physically, the causes, diagnosis, and the treatment options. Like always, we want you to get the key info quickly and clearly, cutting through the noise and definitely in this case, the stigma.
Yeah, and that's so crucial here. Because it's kept under wraps so often, lots of people dealing with this can feel pretty isolated or, confused. Just understanding the how and why and knowing there are actual effective things you can do that could be a game changer.
Absolutely. Okay, so let's get straight into it. What exactly is premature ejaculation? The basic definition seems pretty straightforward, right?
It is. Essentially, it means ejaculating sooner than you or your partner wants during sex, or sometimes even during masturbation.
And the material really hammers home just how common this is. It's like way more common than people think.
Oh, definitely. It affects about 30% of men at some point. That's almost 1 in 3 guys.
Yeah.
It's really not rare at all.
1 in 3. Wow.
But here's the kicker, and it really speaks to that stigma you mentioned. Even though it's that common, the source material points out that only around 9% of men experiencing it actually seek medical help.
9% out of 30.
Yeah. Think about that. 3 out of 10 men might deal with this, but fewer than 1 in 10 actually talks to a doctor about it.
That really highlights the silence, doesn't it? Okay, so if it's this common, let's dig into the mechanics. How does ejaculation actually work? Because I'm getting the sense it's more complex than just, deciding to.
It absolutely is. And understanding this mechanism is kind of key. It works a lot like a reflex arc. You've got sensory signals coming from the genitals, traveling up the spinal cord to the brain.
Okay.
And when arousal hits a certain point, it triggers something called the spinal ejaculation center. It's right there in the spinal cord.
So once that center gets the signal, what happens next? The material mentioned 2 phases.
Exactly. Phase 1 is emission. This is when all the tubes involved, the VSAF difference carrying sperm, the seminal vesicles, the prostate, they start contracting rhythmically, pushing all the fluid into the urethra right at the base of the penis.
And that's the point of no return people talk about.
That's it, precisely. The source really emphasizes this. Once that fluid hits the urethra during emission, it's involuntary. You can't consciously stop it then.
Okay.
And that leads straight into phase 2, expulsion. That's the forceful part. You get these rhythmic contractions of the pelvic floor muscles, the ones around the urethra, and they propel the semen out.
Right.
The force can actually be pretty significant, like 30 to 60 centimeters per second in younger men.
Yeah.
It's interesting, the material notes, it's normal for this to get less forceful as men age, maybe more like a dribble sometimes. That's just weaker muscles, a natural aging thing.
So the really big takeaway here is that ejaculation isn't purely about conscious control or willpower. It's got this reflex component.
Exactly. It's partially reflex. Once emission starts, the body's basically on autopilot for the expulsion part.
Okay.
And just knowing that can help take some of the pressure off,
Yeah.
Helps destigmatize it. It's not necessarily a failure of control. It's physiology happening maybe a bit too fast.
That makes a lot of sense. So if it's common, partly a reflex, what makes it happen too soon? The material is clear. It's not only in your head, even though that plays a part.
Right. And the source distinguishes between 2 main types. There's primary PE that's lifelong. It basically starts from the first sexual experiences happening consistently within, say, a minute or 2 of penetration.
Okay.
Then there's secondary PE. That develops later on, after someone's had a period of, normal ejaculatory control.
Gotcha. And what about the psychological side? Because you said it does play a role.
It absolutely does. I mean, with almost any sexual issue, your head gets involved, right?
Yeah.
If you experience PE, even just once, it can create this anxiety loop. You start worrying about performance, about your partner's satisfaction, maybe feeling embarrassed.
Yeah.
That makes sense. And all that stress just feeds back into the problem. It makes it harder to relax, harder to enjoy sex, which can, make the PE worse. It's a vicious cycle sometimes.
Right. The anxiety fuels it. But you also mentioned the physical side. What are some of those physiological factors?
Well, the material lists a few key things. It could be an imbalance in brain chemicals, neurotransmitters, especially serotonin.
Okay.
There might even be a genetic link. Sometimes it runs in families. Though, as the urologist joked, probably not something you bring up over dinner.
Huh, probably not.
Hormonal issues can contribute too, things like low testosterone or thyroid problems.
Yeah.
And some guys just seem to have higher sensitivity in the glands. head of the penis.
Interesting.
And this is a really important one, the link with erectile dysfunction, ED. Often if a man struggles with getting or keeping an erection, he might feel this pressure to rush through sex before he loses it.
Yeah.
And that rushing can kind of accidentally train the body to ejaculate faster. So the anxiety about the erection leads to the PE. But the good news, and the source highlights this, is if the PE stems from ED, treating the ED effectively often fixes the PE too.
That's a really crucial connection. It's not just two things happening at once. One can cause the other. Okay, so let's shift to diagnosis. This part seemed surprisingly simple in the material. How do doctors figure this out? Is it a bunch of tests?
It is surprisingly straightforward, actually. The source says diagnosis is mostly based on just talking to your doctor. It's not usually about invasive tests.
Just talking.
Yeah. The doctor will ask specific questions. What are your symptoms exactly? How often does it happen? How long has it been going on? Does anything make it better or worse? It's about understanding your experience.
Okay. And there are some specific criteria they use based on guidelines.
Right. Generally, they look for ejaculation happening consistently within about 1 to 2 minutes of starting vaginal penetration. Yeah, consistency is important. But maybe even more important is the presence of distress. The material really emphasizes this. Is it causing you or your partner stress, anxiety, frustration, relationship problems?
So the impact matters as much as the stopwatch.
Exactly. And it needs to be recurrent, happening pretty much every time. The urologist actually mentioned that the distress factor is often the biggest driver for seeking treatment. The goal isn't just lasting longer by the clock, it's about mutual satisfaction.
That leads to that reality check point they made, which I found helpful. The average time to ejaculation during sex is actually around 5 to 6 minutes.
Right, so if you're already lasting that long or more, maybe aiming for 15 or 20 minutes isn't realistic if you've never done that. It kind of opens up a discussion about expectations, yours and your partner's.
Makes sense.
The doctor will also, consider ruling out underlying medical stuff, maybe some blood tests for hormones like testosterone or thyroid. And they'll think about whether psychological factors or relationship issues are significant, perhaps suggesting seeing a therapist or counselor.
Okay, so it's common, it's complex physically and psychologically, and diagnosed mainly through conversation. What can actually be done about it? What are the treatments?
The good news is there are quite a few options. And the source suggests that the best results often come from combining approaches, lifestyle changes, maybe techniques, sometimes medication.
All right, let's start with lifestyle. What did the material suggest there?
Lifestyle changes are seen as a really strong foundation. Regular exercise comes up a lot, especially things like high-intensity interval training, HIIT.
Why HIIT?
Well, it has several benefits. Better cardiovascular health, obviously good blood flow, stamina. But exercise, including HII and things like yoga or running too, can boost something called interoceptive awareness.
Interoceptive awareness.
Yeah, it's basically being more tuned in to your body's internal signals. So you get better at recognizing those rising arousal levels and noticing that point of no return getting closer.
Okay, so you had a better warning system?
Kind of, yeah. Exercise also helps balance your nervous system, promoting the parasympathetic side, the rest and digest system, which can help delay that ejaculatory reflex. And of course, it's a great stress buster, which helps break that anxiety cycle we talked about.
Did they mention any specific studies on exercise?
They did mention a couple, acknowledging they're small but promising. One trial with Chinese men found daily 7-minute HII sessions helped significantly in just 2 weeks. Another look at yoga studies showed it could increase latency like from 30 seconds to nearly 2 minutes in one study.
Wow, that's quite a jump.
Yeah, almost as effective as some meds in that particular study. So these are really accessible, safe things people can try. Pelvic floor exercises, Kegels are also recommended. Strengthening those muscles gives you more conscious control down there.
Makes sense. What about specific techniques someone can practice?
Behavioral techniques are a big part of the toolkit. 2 main ones were discussed. First, the start-stop method.
Right, I've heard of that one.
The idea is basically to train your body to handle high arousal without immediately ejaculating. Yeah. So you stimulate yourself, or your partner does, until you feel that urge coming on strong right before the point of no return.
Okay.
And then you stop completely.
Yeah.
Just pause, maybe take some deep breaths, let the arousal level drop back down a bit. Once the urge fades, you start stimulation again.
And you repeat that.
Yeah, the usual advice is repeat the stop-start cycle 3 times, and then on the 4th time, you let yourself ejaculate. Doing this regularly helps build control.
Okay. And the other one, the squeeze technique.
Right, it's a variation. When you feel that urge building, instead of just stopping, You or your partner gently but firmly squeezes the base of the head of the penis where the head meets the shaft using the thumb and forefinger
Squeeze it.
for about 10 to 20 seconds. This pressure actually helps reduce the urge and maybe some rigidity. Then you pause, let things calm down, and restart stimulation. Like start-stop, you can practice it alone or with a partner. Communication is key there, obviously.
Definitely. The material also mentioned using devices. How do they fit in?
Yeah, masturbation devices can be useful. They offer a controlled way to practice these techniques. And some are designed to feel more like partnered sex than just using your hand.
Right, to make the practice more relevant.
Exactly. It helps transfer the skills you learn during practice into, the real thing. And maybe they offer some desensitization over time, too.
Were there specific examples?
Yeah, a few were mentioned along with small studies. The MyHixel device, which tries to mimic the vagina with temperature and vibration, showed latency improving from about 1 minute to over 4 minutes in one study.
Okay.
The Tanga flip pole helped with control and distress in men with lifelong PE in another study, though they didn't track time specifically. And the Tanga men's training cup, which has different tightness levels, saw latency go from about 1.7 minutes to nearly 4 minutes in its study group. It's important to note these are small studies, and one had a high dropout rate. But the idea is that practicing with something that mimics intercourse might be more effective for skill transfer than just hand masturbation.
Okay. Lifestyle, techniques, devices. What about medications? You mentioned earlier there aren't any specifically FDA approved just for PE.
That's right. No drugs approved only for PE in the U.S., but several medications are used effectively off-label.
Off-label, meaning approved for something else, but doctors use them for PE.
Exactly. Topical anesthetics are one category, creams or sprays with lidocaine, for example. You put them on the head of the penis a little while before sex.
To numb it slightly?
Yeah. Reduces sensitivity. They can work quickly, which is good. Downsides are potential numbness affecting erections or transferring the numbness to your partner.
Right. Got to be careful there.
Then there are certain antidepressants, the SSRIs, drugs like fluoxetine, paroxetine, sertraline. You might know brands like Cymbalta or Paxil.
Antidepressants for PE. How does that work?
Well, they affect serotonin levels in the brain, and a known side effect is delayed ejaculation. So doctors leverage that side effect. Usually you take these daily, and they take a few weeks to kick in.
Okay. Any drawbacks?
Potential side effects like lower libido, maybe nausea or fatigue. And if you stop taking them, the PE symptoms often come back. There's also an on-demand SSRI, duloxetine, but it's not available here in the States.
Gotcha. And what about ED meds, like Viagra or Cialis?
Ah, yes, the PDE5 inhibitors. This is really crucial, and the source is clear. These only help PE if the PE is caused by or directly linked to the ED.
Okay, only if ED is the root cause.
Right. If you fix the erection problem, the PE that was happening because of the erection anxiety often goes away.
Right.
But they don't treat PE on their own if ED isn't part of the picture. They have their own side effects too, like headache or flushing, and need stimulation to work.
Makes sense. Any others mentioned?
Briefly, yeah. Tamsulosin or tramadol were mentioned as other off-label options that have been studied, maybe if the other things don't work. So the big picture on treatment is really that it's not one size fits all. Often the best results come from combining things lifestyle, techniques, maybe a medication, and especially for secondary PE, the kind that starts later, it's super important to look at what else changed, stress levels, relationship issues, other health stuff. Addressing those root causes is key.
Okay, so let's just quickly recap this deep dive. Premature ejaculation. Way more common than you'd think, like 30% of men. It's got roots in both our psychology, anxiety, stress, and our physiology, that ejaculation reflex. Diagnosis. Surprisingly, it's mostly about talking honestly with your doctor, not tons of tests. And treatments. There's a whole toolkit. Lifestyle stuff like exercise, behavioral techniques like start, stop, and squeeze, training devices, and several effective off-label meds.
And just remembering, like we said, that it often involves a physiological reflex. It's not purely willpower. That alone can really help reduce the stigma and make it easier to seek solutions.
Yeah, absolutely. Hopefully this discussion has given you some really valuable information, maybe cleared up some confusion or sparked some aha moments about something that really deserves more open conversation. So we'll leave you with this to think about, drawing from the source material. Given how incredibly common PE is, and the fact that understanding its physical and psychological mix can lead to effective treatments, why do you think it's still such a hard thing for so many people to bring up, even with their doctor or perhaps especially with their partner? Something to mull over.